Just let me know when are we live? Hello, I think we are. We're just waiting for people to arrive. So welcome. And we're going to wait a few minutes while people join. We can see people joining now. We still have a few people joining. It's just 8 o'clock, so we'll just give it another little bit to see if people have been settled in, and then we'll begin. Looks like we have a prompt group. I think they're all in for now. I am going to give it a little bit more. Okay, I think we're going to get started. Welcome, everyone. We're so glad to have you here. I'm Christine McDonough, and I want to welcome you to this live question and answer session, 30-minute question and answer session with the authors of the Clinical Practice Guideline for Physical Therapy Management of Older Adults with Hip Fracture. We hope that you were able to preview our presentations that were pre-recorded, and I just would like to express our thanks for the invitation to do this work with the Fragility Fracture Network. This whole event was initiated and organized by and sponsored by the Fragility Fracture Network's Physiotherapy Special Interest Group, of which Morten Christensen is a co-lead. And it is also co-sponsored by the Academy of Orthopedic Physical Therapy. And we want to thank our kind Melissa and Tara for setting up this webinar and being here. They're in the little squares of AOPT. So thank you very much. We want you to start, if you can, to think about the questions that you have and put them in the Q&A while I'm introducing, so that we can have some discussion on the things that most interest you. After I introduce the authors, I will begin to read the questions in the Q&A feature, and we'll have discussion from the authors on those topics. So I'm pleased to introduce to you the authors who are Tom Herring, Marcy Harris-Hayes, who cannot be with us tonight, Kate Klein-Mangione, Morten Christensen, and Jan Overgaard. And I just want to highlight that yesterday for our European live question and answer, poor Tom Herring was with us at about 4 o'clock in the morning. And right now, Morten and Jan are here from Denmark at 2 o'clock in the morning. So we're very grateful to have them up in the middle of the night for this live Q&A. It was very nice. We told them they could just beg off, and they still came. So panelists, anything that I missed? Okay, no, okay. So I think we'll get started. We don't see any, we got some more peeps in there. Welcome everybody that's just joining. We're about to start the Q&A. We have had some interactions over social media about the clinical practice guidelines, and some questions have come up. So we wanted to just sort of start the discussion with a few questions that were brought up in the social media discussions, and also perhaps one that had come from the live Q&A, the European live Q&A. I see one coming up there. Thank you in the Q&A. So I'm just going to start off with Tom Herring and ask you to address one question that came up, which was why the clinical practice guideline doesn't call out recommendations for nutrition. Tom, could you address that?
Yes, I think that we can look to the guideline and see that in several areas we do identify nutritional risk factors. And some of those that we identified are low BMI, vitamin D deficiency, low dietary calcium intake, and hypervitaminosis A as risk factors for having a hip fracture. We also identified inadequate nutrition as evidenced by a low albumin of less than 3.5 grams per deciliter, a vitamin D deficiency of 32 nanograms per milliliter or less, and anemia of 3.5 grams per deciliter or less. We identified those items as risk factors for poorer outcome and increased mortality after having a hip fracture. We recommended assessment for nutritional deficiency as a pressure ulcer risk factor also in the guideline. And we specifically included nutrition services as a component of the care team. But based on this comment, future revision should include a referral to nutritional services for secondary future prevention and on transfer from hospital to the community when nutritional deficits have been identified.
Thank you, Tom. That's really helpful. Any comments from the panelists? These are always challenging when the topics of the clinical practice guideline are overlapping with other really important topics, but it's a challenge to define the scope of the guideline such that it's feasible. So these are always areas that we struggle with and we like to consider as we think about future versions of the updates and revisions of the guideline. So we were glad to have that feedback. We had also similar feedback in regard to vestibular assessment of vestibular disorders. Tom, could you address why vestibular disorders are similarly not called out in the clinical practice guideline?
Well, on the surface, it would appear that this is an even greater void in the guideline. And I found it so curious after we spent, as a team, we spent years researching risk factors for hip fracture and risk factors for poor outcome after hip fracture. And none of the literature that we examined identified any specific vestibular disorder or vestibular disorders in general. Of course, we know that vestibular deficits lead to falls and falls lead to injuries. So I took this question to a colleague who was on the revision team for the vestibular guidelines. And her response was that the subject may not lend itself very easily to research because falls can cause vestibular deficits, but vestibular deficits can also cause falls. So it kind of muddies the water a little bit. She also suggested that a vestibular assessment was probably not an appropriate thing to include in the guideline because it requires a skill level that the average practitioner, the average clinician may not have. It also may require specialized equipment to identify some of those vestibular disorders. What she did suggest was that balance interventions should be included. And in fact, we did include balance interventions in the guideline. And she suggested that something that physical therapist or the clinician could look for as they're assessing that patient postoperatively is vertigo, dizziness, lightheadedness, or sudden onset of hearing loss. And if those things are found, then that would trigger or should trigger a referral for a vestibular assessment.
Thank you very much.
Can I add a little bit to that one? So
yeah, please.
So what's really interesting as a researcher so I get to see literally hundreds of hip fracture cases, and we always look to see why the patient falls. And it's not in my common recollection that people report dizziness as often as slips and trips and ice and carrying something. There's typically a lot more other reasons. And so where I do think that absolutely there must be some cases related to vestibular issues, I don't think it's a major issue, and I agree that it's going to be a very complicated thing to study, but I would say that that's going to be an exception more so than the rule for most fragility fractures.
Thank you. Thank you. Okay, I do have a couple of items in the Q&A, which is great. And we have one that I think is going to come to you, Kate, about the post-acute session. It says, and I'm going to read a little bit to you, Kate, to cue you for the discussion. But it says, I was interested in the discussion of motivational interviewing on activity following fracture. I downloaded the article, but I haven't had an opportunity to read it yet. Is it possible to give a brief summary of the techniques and research protocol of that study? So that was
not by me. It's not.
No. I was going to say, well, I have that in my memory, but probably not all of the detail of it. But I can say it is, we tried to summarize in the clinical practice guideline the main parts of it, but not the specific procedures. So it was investigating the effect of motivational interviewing added to usual care. So would that help people to follow through on physical activity behaviors? And
I might join in on this, Christine.
Go for it.
There's a number of studies, and I know one of them is actually physical therapists calling patients once a week and motivating them to get out and walk, outdoor walking. So, and I think it's mainly Australians that did some of these studies, and at least one of the studies was actually like phone calling patients once a week to motivate them to get out and walk, and that seemed to work quite well. It might not be the study that the participant referred to, but that's at least one of the studies that was in this group of motivational interviewing studies.
Yeah, it could be the O'Halloran study.
No, it is O'Halloran. We found that to be a level 2 study, and I do have some detail there, but it sounds like you do too, Kate.
So I just have my other resource with me. Thankfully, I have more than one device because I'm like, uh-oh.
So I can help you if you want, but if you have it there, go ahead.
No, I really do think it's the addition of motivational interviewing, and my recollection is that it was the systematic way of doing it, of really going through that whole process of motivational interviewing, a little different than what Morten's talking about. And so I do not personally know those techniques method-wise. I do know that good geriatric practitioners always seem to find what's meaningful for the patient and do that whole, what's important to you, and let's make that our goal. And that's some of the basis, very, very generally speaking, the basis, but I don't have the details on the methods they use for motivational interviewing. Christine,
yeah, well,
if you
I can speak to it a little bit. I can say that essentially what's highlighted in the methods is how they trained the actual physical therapists in motivational interviewing. And they focused really on that. They had a 2-day workshop and they had role playing, and then they tested whether they were accurate in their application of the principles of motivational interviewing. So they don't give as much detail on kind of the implementation, which is very common. I mean, it's one of the things we want to call out about all of the research that we found in hip fracture is that understanding how the intervention was actually done in practice in the study is often very difficult. So they do say that the 12 of the 13 participants completed the intervention. They received scheduled 8 sessions of motivational interviewing. So basically, it's formal training and then providing 8 sessions of motivational interviewing to each participant. And basically, everybody was able to do it. They participated in it, which is an important thing. It says 12 of the 13 went to 7 sessions. The sessions lasted 30 minutes. So I'm hoping that helps. I think we called out a couple of limitations that I would just bring to your attention, which was, I think you can read it, but essentially it was a small sample and lack of long-term follow-up gave us a little bit of pause in making a specific recommendation around motivational interviewing. First of all, we don't feel comfortable making a recommendation on only one study pretty much ever, unless it's a systematic review that is high quality. But one single study is pretty much a place where the evidence is not clear at that stage. One study, does not answer a question. There's always limitations. You can't avoid it. So while we wanted to mention it, because we know it's an evolving area, and just as Morten said, there are more studies out since we finished our review, but we didn't want to name it specifically. We wanted to highlight it, and we feel that we would follow it in future updates of the clinical practice guideline to see if that evidence has gotten stronger. I hope that helps. Mike Anderson is the person that asked that question. He says, yes, it does help. Oh, wow. Thank you for all the discussion. Yay. I think there's another chat. I think there's a little bit in the chat. So I think I want to make sure. I'm going to slide it over. If you'll have a little patience with me, I'm just going to see if I can see that chat because it's not really easy for me to see. Okay, so now Ruth, I don't know if this is on the topic, Ruth. I'm going to read it, the most important thing. Okay, that I think I'll come back to later. Okay, so Mike seems to have found that useful. Let's go on to Laura Godart. Says, are there any specific recommendations for helping patients regain hip rotation active range of motion following hip fracture and open reduction internal fixation in the chronic phase, 6 months to 1 year after reduction and internal fixation? Or any guidelines for how much hip rotation active range of motion they should expect to regain? Specifically, external rotation active range of motion to help positioning for donning socks and footwear. Now for that one, I think, who's my early post-op? Sorry, I can't see it.
You know what? I would think, can we punt this to Jan because he's in the outpatient setting and I think he gets to do a lot of these.
And also because he got up at 2 a.m.
That's right. He needs a question. So I think he's a...
Thank you, Kate.
My pleasure.
Jan, we volunteered you.
Well, yeah, thank you. Well, I'm not aware of there's any guideline for PTs to follow, but mostly here in Denmark, it's according to what the surgeon is telling us to do. There's going to be some restrictions after the surgery. We have to follow that one, but otherwise, I'm not aware there's any guideline to follow. Maybe and
then I'd like to check in with Morten too, just because I had tagged you for early post-op, Morten.
Yeah, but it's okay, and I think it's a good question, and it might be a bit overlooked actually, because well, as Jan said, there's no guidelines for them, and I think we aim to recover full range of motion, except for those with restrictions after arthroplasty. So, but actually, I can't come up with anything specific. Of course, in the early stage, it will be difficult because they have some pain and there will be some swelling, edema related to the trauma and the surgery, and especially depending on the type of fracture. Trochanteric fractures will experience more pain, and they will also have more edema related to the fractured leg. So, but later on it will disappear. So, and they don't have any restrictions, those with osteocentesis. So I think you will have to use your physical skills and try to get the normal range of motion back. That would be my best answer, but it's a bit overlooked, I think.
I think that the person asked for the longer, though. I think the question was the chronic phase, 6 to 12 months.
6 to 12 months. Yeah.
6 months to 1 year. Thank you, Kate.
Yeah, no, and I think what that speaks to is the fact that we're not doing it early, that they're having such problems in the chronic phase. And so they shouldn't have problems in the chronic. If we're trying to, change something after 6 months of no motion, that's going to be the real issue. And so allowing, again, early movement and as much movement as possible. And I do think acutely, some of we're so interested in function, which I think is appropriate, but some of those other functions, really difficult things like putting on your shoes and socks, like you suggest, is really it's a complicated task. But again, I think the earlier the better. Once you're in the chronic phase, now you have soft tissue it's going to take a lot longer to really try to get that range that you need.
I think they also, wasn't it referring to external rotation?
Yes.
And I think that there's rarely, even immediate post-op, there's rarely going to be a restriction on external rotation, range of motion. And even down the road, I think gentle manual passive stretching, inflection and abduction with some joint mobilizations that the clinician feels comfortable with is probably going to be their biggest tool.
So I want to highlight to Tom, thank you for jumping in there, because I know, that's an area for you as well. And I also would like to highlight as a team that has worked to create recommendations to improve care and with a focus on improving outcomes for the patients. This kind of discussion is really helpful because, for example, if we have a sense that this could be a place where our interventions could be targeted and improve outcomes at 6 months to 1 year, if we do something as a whole, as a community differently, that's something of great interest to us. But I think we might have to target the literature a little bit to that question about limitations in external rotation, range of motion, and related function. So I think it's something that I think I at least would pay attention to see if it's something we should be looking at more closely. Is that fair, panelists?
Yes.
Yeah, sure.
Absolutely. Yep.
But I would say that, it did not jump out at us in the studies that we looked at, although we didn't target that. Okay. I do see another question, which is there any information on outcomes depending on the initial weight-bearing status? If this is coming to you, Tom, I'm going to finish it in a sec. You're getting all excited. Is there any information on outcomes depending on initial weight-bearing status immediately following surgery? And take it away, Tom.
Well, Morten can speak to this too, but we can all speak to this.
Yes.
There is a preponderance of evidence that shows that early weight bearing correlates very strongly with a positive outcome, and restrictions on weight bearing correlate very strongly with increased mortality and morbidity. And it's probably been one of the strongest motivating factors for the development of orthopedic hardware that permits early weight bearing. That's what's really saving us as clinicians. Without that hardware, we would not be able to do what we know we need to do.
And I thank you, Tom. I want to go to Morten for sure, because you have clear expertise.
I completely agree with Tom. It was a great way to present the literature, and I think, but there's still many areas around the world where many patients have restrictions. And just about 10 years back, I was involved in a study from southern Spain, and about 40% of patients, they were not allowed weight bearing within the first 2 to 4 weeks after surgery. And we studied it, and they were followed for 1 year. And as Tom said, they had lower functional ability, and more of them died with restrictions. And there's no reason for that. In Denmark, it's about 98. It might be 1 or 2% that are not allowed full weight bearing right after surgery, and without any X-rays. It's the surgeon in the theater who decides, is this stable? And we can mobilize. We don't have to wait for the X-ray following surgery. And that might not be the case in the US. It might be a bit more conservative and wait for an X-ray. I actually don't know that, but it's a strong recommendation. You don't have to wait to let these patients weight bear as tolerated. None of them will take full weight bearing anyway. So.
Mm-hmm.
Thank you. That's much appreciated. Kate, I think I'd like to, wait a minute, let me see. We're getting some action in the chat, I think. Weight bearing as tolerated, says Ruth, what a difference it makes. And then it says, thanks for your comments on weight bearing status. I still see some orders for non-weight bearing and know it is issues acutely. Thanks. So good. Thank you for your comments in the chat. And I would just warn you, go ahead. Can I just make one warning? Jan, anybody who has a lingering question, jump in there and put it in the Q&A, because we only have time for probably one more. So please put it in if you have a hiding question. Jan, please go ahead.
I was wondering if it's normal practice to do, but when I was working at a hospital, sometimes I had a discussion with the surgeon about weight bearing status. And it's, I guess you can do that. Talk to the surgeon and see why is it there any restrictions on weight bearing.
You know, this is ages ago for me, and in a particular health system. But when I was in inpatient orthopedics in my training years, we actually had physical therapists who were part of the training, the entire training program for all residents and fellows. And the fellows had always had a physical therapist, kind of a lead physical therapist who rounded with them in order to make sure these things didn't happen. And they were considered part of the training for the fellows and the residents. And that created a situation where they were able to kind of learn from the physical therapists what they knew about the functional side of the rehabilitation. And it's a model that I thought was very, very helpful. You know, you may not be able to implement that in your setting, but you could be open to looking for opportunities for interaction and sharing information. Now, the other thing I have to say is one of the reasons we do these incredibly detailed clinical practice guidelines, which, you know, you can't imagine you want to read this cover to cover, right? But it gives you information that you can simply use in those conversations. You don't have to necessarily go look up all the literature, because we did. And we put it in there for you so that it would help you if you need to have a conversation to enlighten or start a dialogue with people in the interprofessional team. You are armed with the best we can do for the evidence for you.
Christine, can I make a quick comment?
Of course.
I recently had a discussion with an orthopedic surgeon and was able to convince him to change the weight-bearing status from non-weight bearing with this argument. When a patient is upright, standing, non-weight bearing, the weight of the lower extremity is actually putting the fracture in traction rather than compression. And of course, we want compression of that fracture to promote healing. And he did change the weight-bearing status from non-weight bearing.
Yay, Tom.
Yeah.
I want to shift a little bit abruptly because we're getting close to the half-an-hour point. I want to thank all of the panelists for sharing their experience, and really thank all of you who joined us in the evening to talk about hip fracture. You know, I hope that you enjoyed the recordings, and if you have other questions, feel free. You have all of our contact information in the clinical practice guideline. Reach out to us. We really appreciate your participation and your ideas and your comments. It helps inform the next steps. And now I'd like to, if I could, hand it over to Kate Mangione to sort of kind of bring things together and finish us off.
Sure. And I just want to put in one more little plug for the Fragility Fracture Network. And I see Monica Pericini's on here and Dale Avers, one from Brazil, one from the US, who are just also getting involved in this organization that really is all about fragility fractures. So it's a great little group that I hope that you can look into. I think what's really wonderful about what we did was we looked at the whole spectrum of care. We looked from acute care all the way through, a year, 2 years post, and with the goal of really saying that the patient needs to get back to their prior level of function, back to participation. And it is through interprofessional management that is so important, as we know, across all of the different spectrums. We used level 1 grade A evidence, and we also include expert opinion. So we have wonderful clinicians and wonderful research that really helped to put this all together. And I think the other thing I want to talk about is a little bit just is the outcome tools that we really included a lot of places. It was really robust literature. And I think some of the things that we don't tend to use too much in the US is something like the new mobility score, which we really look and quantify what was their prior level of function. If we would use the same measure from their prior level of function across the continuum of care, we would really know when patients got back to doing what they were doing before. So we have a lot of great measures and a really holistic view of total management of the patient with hip fracture. And hopefully all of you guys, thanks again for attending, and we know that you're going to provide the best care you can. So thank you.
And I'm sorry, I need to comment to the chat. The clinical practice guideline is openly available on the Journal of Orthopedics and Sports Physical Therapy. You can just Google it, Google hip fracture guideline, JOSPT. It's openly available. You can download it as a PDF without any membership. Thank you. Thank you all very much.
And also, I could say that all the on-demand videos and also videos from these webinars, they will be available at the same FFN YouTube channel that you got the link to when registering. So you can look at them later on also. Thank you.
Yay. All right.
Thanks.
Thank you very much. Good night.
Good night.